Welcome to the chapter summary for Chapter 8, Revenue Cycle Operations. The revenue cycle could be considered the heart of the organization, and it impacts patients and their families, physicians and other providers of care, ancillary departments such as radiology and laboratory, support departments such as scheduling and registration, finance, HIM, clinical documentation, patient financial services, as well as information technology. The revenue cycle refers to the sequence of processes to progress a patient's account from creation to closing. Okay, so think about the entire cycle. Okay, so healthcare revenue cycle management, RCM, refers to the strategy implemented to direct administrative and clinical functions associated with capturing, monitoring, and collecting of patient service revenue. So HIMSS, HIMSS, defines RCM as a healthcare organization's financial circulatory system, which I love, and a basic process of the organization securing reimbursement for the products and services rendered to their patients. In practice, RCM involves balancing people, tools, methodologies, technology, and the environment in which processes take place. So combining efforts across departments and staff members to improve the revenue cycle processes and establishing performance expectations will lead to a successful revenue cycle operations. Sorry, I think I jumped ahead a little bit. Let me go back. Yes. So I mentioned revenue cycle, right? The start of it. And again, it ends when payment for services are rendered and an account is closed. So to reiterate, success of revenue cycle depends on the people, the tools, and technology, as well as the processes. I'm not sure why things are jumping on me this morning, but either way, bear with me. The revenue cycle can be broken down into three general phases. Okay, the general phases of the revenue cycle includes the front end, okay, which is represented here, right? Your front end, your middle end, and your back end processes. So the front end, let's talk about the front end. The front end of the healthcare revenue cycle starts at the point of scheduling a patient for healthcare services or when the patient presents for services not previously scheduled. So during this phase, healthcare organizations need to establish the source of payment for services rendered, follow requirements specified by the payer, accurately collect the patient's demographic information, and ensure a positive patient experience. So let's now talk about the middle process, right? So the middle process of the healthcare revenue cycle represents the intersection of clinical practice, documentation, and coding with charge capture to bill for services provided. The middle process also includes case and utilization management. The key objectives are to manage clinical practice and charging within accepted guidelines to ensure reimbursement, document services completely and accurately, and to ensure coding of documented services. So we want to make sure that coding is accurate and complete. So I think it's important to keep in mind that HIM, or coding specifically, is going to be captured in the middle part of revenue cycle. Okay, so then when we think about the back end of revenue cycle, right, this is the part that we're focusing on. The back end of revenue cycle involves all aspects of claims processing to prepare and submit a claim for payment. Once a patient has ended their encounter, the goal is to generate a complete and accurate claim and submit for payment as quickly as possible. So revenue cycle versus a life of an individual account. The term revenue cycle suggests the patient's account flow is cynical, right? Or think of the circular motion, right? Cylindrical. So the life of an individual patient account flows through specific stages from beginning to end. Okay, so healthcare revenue cycle for an individual account. Note that additional support services are imperative to the healthy flow of management, the revenue management life cycle, excuse me. Payer relations and patient relations are essential functions while not directly involved with an account moving through the cycle, okay? So I wish I could make this a little bit bigger for you. However, I think you should be able to enhance it if you need to. So understanding your front end processes includes scheduling, pre-registration, as well as registration, right? And then when we get to the middle process, we talked a little bit about providing services, documenting, right, the HIM aspect, capturing those charges, and then it goes through the billing cycle. So this is a great visual to understand how the revenue cycle is outlined, right? So a tip, emphasize how each stage within each process is a position opportunity for HIM professionals, right? Especially if you don't have HIM experience. I've seen many HIM professionals start perhaps in patient registration, right? Or other aspects of the revenue cycle and work their way over to HIM. So revenue cycle front end processes. Again, I just mentioned this. It includes the patient access components such as scheduling, pre-registration, insurance verification, pre-authorization, and pre-certification, medical necessity coverage issues, or at least addressing those medical necessity coverage issues, registration in general. So if financial counseling is needed, and then the point of service collection and any additional pre-encounter services. So patient access components. So patient access represents the stage where the patient encounter is initiated and involves the processes of scheduling, pre-registration, and registration. So accuracy of information captured in the patient access stage is vital to many of the processes occurring later in the revenue cycle. And the goal is to continuously improve data collection and accuracy. So initiating the registration function during scheduling saves time and is often more convenient for patients when they arrive for their services. So each time a patient presents for clinical services, the data collected during the previous encounters need to be verified for accuracy and updated to address any changes to prevent potential registration errors. So scheduling patient services. So when we schedule patient services, we want to make sure we obtain the source of payment, collect patient demographics, validate patient information upon arrival if pre-registered, right? And contribute to an excellent patient experience, which I already mentioned. So accurate communication is essential to the beginning of the visit. To the beginning of the visit, right? We want to enhance patient satisfaction and initiate appropriate revenue. So initiating the registration function during scheduling saves time and is often convenient for patient when they arrive for their services. So each time a patient presents for clinical services, again, the data is captured from previous encounters. So we need to make sure that it's verified and accurate and updated to address any changes. Um, So again, when we mention, okay, so some front-end processes, these are some examples of common registration errors that take place on the front end, right? So internal coding mismatches, which financial class, patient type to state type to service code to admit code, invalid punctuation in specified text field. So insurance eligibility verification failure, observation patient and inpatient state type. Welcome to the Chapter 8 summary on revenue cycle operations. So the revenue cycle could be considered the heart of the organization as it impacts patients and their families, physicians and other providers of care, ancillary departments such as radiology and laboratory, support departments such as scheduling and registration, finance, health information management, clinical documentation, patient financial services, and information technology. So the revenue cycle refers to the sequence of processes to progress a patient's account from creation to closing. Healthcare revenue cycle management, also known as RCM, refers to the strategy implemented to direct administrative and clinical functions associated with capturing, monitoring, and collecting of patient service revenue. HIMSS, HIMSS, defines RCM as a healthcare organization's financial circulatory system, which I just love, and basic process of the organization securing reimbursement for the products and services rendered to their patients. In practice, RCM involves balancing people, tools, methodologies, technologies, and the environment in which the processes take place. So combining efforts across departments and staff members to improve revenue cycle processes and establishing performance expectations will lead a successful revenue cycle operation. So again, revenue cycle, sorry, I forgot to change my slide. Okay, so again, a revenue cycle ends when payment for services are rendered and an account is closed. So the success depends on people, tools, technologies, and processes. Okay, so let's talk about the different aspects of revenue cycle, or the different processes of revenue cycle. So the revenue cycle life cycle can be broken down in three general phases. The three general phases include front end processes, middle and back ends processes. So the front ends of healthcare revenue cycle starts at the point of scheduling a patient for healthcare services or when the patient presents for services not previously scheduled. So during this phase, healthcare organizations need to establish the source of payment for services rendered, follow requirements specified by the payer, accurately collect the patient demographic information, and ensure or ultimately ensure a positive patient experience. So the middle process of the revenue cycle represents the intersection of clinical practice, documentation, and coding with charge capture to bill for services provided. So the middle process also includes case and utilization management. So the key objectives are to manage clinical practice and charging within acceptable guidelines to ensure reimbursement, documents, document services completely and accurately, and to ensure coding of documented services. We want to make sure that, of course, is complete and accurate. So the back ends of the revenue cycle involved all aspects of claim processing to ensure and submit, or not to ensure, excuse me, to prepare and submit a claim for payment. So once a patient has ended their encounter, the goal is to generate a complete and accurate claim and submit it for payment as quickly as possible. Oh, okay. So revenue cycle versus life of an individual account. So the term revenue cycle suggests that the patient account flow is cylindrical, right? And then the life of an individual and patient account flows through specific stages from beginning to end. So let's take a look at the individual account. So I wish I can make this a little bit bigger, but hopefully you see this. So it describes the front end processes and provides examples for those, the middle processes along with the example for those, the back end process. Also notice how they're color coded, right? So no additional support services are imperative to the healthy flow of revenue management lifecycle. So payer relations and patient relations are essential functions while not directly involved with an account moving throughout the cycle. So a tip would be many people who want to get into HIM or who are seeking a position in HIM, they also look for positions throughout the revenue cycle, right? So if there aren't positions available in HIM, can I get a position in patient financial services or registration to help better understand the revenue cycle, the impacts that the department, in addition to or HIM, right, have on the revenue cycle. So there's tons of opportunities, right? So if you're thinking about entering into HIM or you're thinking about looking for positions surrounding revenue cycle, right? Think about these. think about these areas and how you can, which areas best align with what you're trying to accomplish. I don't want to get too much into this because I could, but that's not what we're here for. We're here for a chapter summary. So I am just going to leave it at that and keep moving forward. All right, so let's talk about those front end processes. So your front end processes again include scheduling, pre-registration, as well as registration. It also includes, or some additional components, I should say. When we talk about pre-registration, that's going to involve the insurance verification, pre-authorization, and any pre-certification that's required. And then we want to make sure we address any issues surrounding medical necessity coverage. Okay, so when we talk about registration, any financial counseling that needs to be done will be done at that time, and then any point of service collection, okay? And then also included in the front end process is going to be your pre-encounter services. So let me go back really quick. So patient access represents the stage where the patient encounter is initiated and involves the processes of scheduling, pre-registration, and registration. So accuracy of information captured in the patient access stage is vital to many of the processes occurring later in the revenue cycle. And the goal is to continuously improve data collection and accuracy. So initiating the registration function during scheduling saves time, and it's often more convenient for patients when they arrive for their services. So each time a patient presents for clinical services, the data collected during previous encounters need to be verified or must be verified for accuracy and updated to address any changes to prevent registration errors. So scheduling patient services. So scheduling patient services at this time, you're going to obtain the source of payment. You're going to collect demographics, right? You're going to validate the patient information, especially upon arrival if they pre-registered. And then you're going to make sure you, yes, you contribute to an excellent patient experience. So really quick, I don't want to elaborate too much here, but I really like that this provides examples of common registration areas because I remember when I was the HIM director, we would, of course, our department might have to fix such errors on the back ends, but I used to make sure that I follow up with the director of patient access or registration to communicate such errors because clearly someone needed training, and we wanted to prevent these errors on the front end if we could. So some examples of common registration errors. Transposed digits, right? So whether it be social security number, date of birth, policy number, or group number, I like to say that I have a numeric form of dyslexia. So whenever I see numbers or I try to give numbers or I'm given numbers, they tend to mix up a little bit in my head. So you always want to double check that, right? Misspelled names are common. Address verification or failure to verify that address, right? Because then when we send out things from the hospital, whether that be the bill, or just information that we're trying to get to the patient and it gets returned, right? Which is another expense um, or cost to the facility, right? And then again, the point of service collection failure, failure to take that payment or secure that co-payment are some errors that could happen. All right, so let's keep going. So insurance verification. So during pre-registration, insurance verification includes ensuring patient demographic and insurance information to be or to ensure that it's complete and that it's correct. So, in the absence of proper eligibility determination, payment for services may be delayed or even denied. So, this also results in claims needing to be reprocessed or reworked, adding additional delays in receiving payments for services, and patients may become dissatisfied due to late statements and increased financial responsibility for services. So during insurance verification, we want to make sure to validate the patient as a member of an insurance plan. We want to determine if that plan is in network or out of network, right? We want to determine if scheduled services, if the expenses are covered, if they require a referral or a prior authorization or an out-of-pocket expense, right, or a copay. So let's talk a little bit about the pre-authorization and pre-certification. So your pre-authorization requires healthcare providers to obtain permission from the health insurer prior to predefined services being provided to the patient. Okay, so your pre-certification is a little bit different, and it's when the insurance carrier must review the proposed service or procedure first and approve it as medically necessary before payment will be granted to the provider. Okay, so one requires that the healthcare provider obtain permission, right? Authorize, they must authorize the service and or the predefined service, and then the certification, the insurance company must certify, right? Give permission, approve it to say that it's medically necessary before payment will be granted. All right. So pre-authorization and pre-certification, your staff needs to understand that medical procedures and tests, initial diagnoses, and scheduled treatments to obtain the necessary pre-authorization or pre-certification required. Okay, so there can be a wide variation in authorization and certification requirements, and this could vary among provider. So insurers, they have established more stringent approval guidelines due to an increase in high technology and high cost procedures and tests. So for example, if a physician orders a um, let's say, I was going to say a PET scan, right? So a PET scan for a Medicare patient, the Center for Medicare and Medicaid Services, CMS, will provide a list of oncology conditions which must be present to receive payment for the PET scan, right? So it's important for healthcare providers to have a current list of procedures and tests that require prior authorization from all health insurers and have processes in place to obtain the authorization prior to services being rendered. So reimbursement for services without pre-authorization is often denied by insurers and results in significant negative financial impact to the healthcare organization. So medical necessity coverage issues. So health insurance companies provide coverage only for health-related services that they define or determine to be medically necessary, right? So Medicare defines medical necessity as a determination that a service is reasonable and necessary for the related diagnosis or treatment of an illness or injury. So the Medical College of Medical Quality, that's your ACNQ. That's an organization whose focus is providing leadership and education in healthcare quality management. AMCQ defines the application of appropriate services and supplies as those that are neither more nor less than what the patient requires at that specific point in time. Okay, so Medicare's national coverage policies are known as the National Coverage Determination, NCDs, another acronym that you need to know. So please write down, right? And then local MAC policies are known as local coverage determinations, LCDs. So I need you to know the difference of those. So a Medicare administrative contractor, which I covered in a previous video, also known as MAC, is a private health care insurer awarded by Medicare for a specific geographic jurisdiction for multi-state or regional contractor responsibilities to process NCDs or LCD policies, or no, I'm sorry. Um, oh gosh, sorry. They are over a specific jurisdiction to process Part A and Part B medical claims, right? So Medicare coverage is limited to items and services considered reasonable and necessary for the diagnosis or treatment of the patient's condition. So your NCDs or LCD policies are not available for every type of procedure or service that could be provided for a patient. So healthcare organizations must maintain knowledge of current regulatory requirements and revisions in order to reduce billing denials and to ensure that payment is received for the services rendered. So in absence of an NCD, or if an NCD requires further clarification, MACs may develop an LCD to cover an item or service. Okay, so medical necessity. So providers are required to issue an advance beneficiary notice of non-coverage, also known as an ABN, another acronym that you need to know, to Medicare patients when Medicare is not likely to provide coverage. So an ABN is a written notice to inform patients when an outpatient item or service is not covered or it's not considered reasonable or necessary, so it may not be covered. So by signing the ABN, the patient is accepting financial responsibility if the payer denies payment. So the patient may not be held financially liable if the patient does not receive a written notice represented by the ABN when it's required. Okay. So the hospital issued notice of non-coverage, HINN. So that may be provided to patients when an inpatient service has been deemed non-covered due to medical necessity. So HINN or HI or HINS, right? HINS can be issued at any point prior to or during a hospital admission. I've seen a question like this on the test before. So or since inpatient medical necessity determination may not always occur during the front end process, the discussion of HINS is continued later in this chapter. So resources to support specific requirements include your payer billing manuals, any Medicare billing manuals, and then your local MAC policies. So I think it's important to understand insurer and payer, right? Does it mean the same thing? Are we using it interchangeable? So in this context, or in the context of this text, or let's say in this chapter, payer and insurer are the same, okay? Okay, so registration, also known as admissions. So in registration, our duties are to verify patient demographics collected during scheduling, obtain copies of the patient insurance card, verify identity using a driver's license or another form of government issued ID, obtain patient consent, collect copayment or deductible, and then initiate financial counseling if applicable. So key fields gathered during the patient access stage to assist in uniquely identifying an individual will include their first name, the first, middle, and last, any formal names or former names, excuse me, their date of birth, their social security number, their residence, their gender, their marital status, their race and ethnicity, their employer, insurance carrier, and a guarantor. The guarantor is the person that's considered responsible for the patient's bill. Collecting complete patient information enhances accuracy of registration. Okay. Sometimes people take that job lightly, right? Oh, I'm just entering data, but that's a very important job because we rely on this data. So we want to make sure that it's accurate. We want to make sure that it's complete. So another important registration function is avoiding duplicating the health record. I think I may have talked about this in a previous video. So we want to make sure that we avoid duplicating the health record number, the account number, or patient identification when the account is originated. So financial counseling. So financial counselors are the staff that's dedicated to helping patients and physicians determine sources of reimbursement for healthcare services. So the counselors are responsible for identifying and verifying the method of payment and debt resolution for services rendered to patients. So counselors need to understand a patient's financial assets and discuss payment alternatives with patients. So some patients are eligible for charity care, okay, which is defined as healthcare services that have been or will be provided, but are not never expected to result in cash inflows. So charity care results from a provider's policy to provide healthcare services free or at a discount to individuals who meet the criteria each organization establishes. So the counselors can establish payment options such as credit card payments, bank loans, and interest-bearing hospital-funded payment arrangements as necessary. Okay. Okay, so I just mentioned this briefly, but strategies for financial counselors can include the ability to provide discount on hospital bills for patients who don't have health insurance and who meet certain eligibility criteria. So the amount of the discount is determined after an assessment of the patient's or family's financial need, and it's typically based on current federal poverty guidelines. An incentive for prompt payment discounts can also be offered to patients. So, point of collection service. So, patients have taken on increasing amounts of financial responsibility for their healthcare costs. The patient financial portion represents approximately 25 to 30% of total net patient revenue, according to Hansen 2016. So, the patient's responsibility is the cost sharing portion, which could involve um, it could involve a deductible amount in addition to a copayment or co-insurance amount. So all payment collection amounts are determined based on the service to be provided and the insurance coverage of the patient's plan. So POS collection works well with scheduled and non-emergent patient visits. So EDPOS collections tend to be more challenging in some situations due to the nature of the visit and the patient's diminished ability to interact. So while the patient is informed about financial responsibility after the medical screening, the requests for payment for ED visits often do not occur until services are complete and the patient is to be discharged. So, pre encounter services. So, many healthcare facilities have combined patient access team resources related to the revenue cycle front end processes and developed comprehensive pre encounter service centers for specific outpatient services. So, the centers typically include scheduling, pre registration, insurance eligibility, benefit verification, payer authorization, and POS collection for all scheduled diagnostic testing and surgery patients. So, healthcare organizations have developed goals to streamline workflows, and performance characteristics are set to support the front end processes. So, combining the front end processes can eliminate last minute cancellations of scheduled services, improve patient flow, and increase patient satisfaction. Okay, so we are going to start talking about the middle process, right? So, what goes on in the middle of revenue cycle processes? So, as mentioned in the beginning, the middle process includes clinical services, clinical documentation, case and utilization management, health information and clinical coding, charge capture, and then your charge description master. So, as the clinical team and the patient interact while services are being delivered, information is documented about the encounter. The patient's visits with the clinical team becomes the basis of the remaining processes within the revenue cycle. So I know I've mentioned this in previous videos, but remember we always say that if it's not documented, it didn't happen, and therefore it's not reimbursable, right? So let's talk a little bit about clinical documentation. So wait, I didn't change my slide. No. Um, okay, so clinical services. Sorry about that. Okay, clinical documentation. So clinical documentation is the foundation upon which to facilitate communication, clinical, legal, and financial. Okay, so complete, accurate, and timely documentation of the patient encounter are important aspects of the revenue cycle. So clinicians must document the services performed and the medical necessity of the services. And staff needs to verify the charges are matching the services rendered prior to, submitting that bill. So CMS regulations require adequate documentation to support payment for reported care provided to the patient. In order to comply with these regulations, hospitals have placed an increased focus on clinical documentation management and coding practices due to their direct impact on the healthcare facility's revenue. So hospitals have invested in clinical documentation improvement programs to assure that the health record accurately reflects the actual condition of the patient, right? How sick are they? So a focus on appropriate clinical documentation can reduce the risk from incomplete and unclear documentation, resulting in loss of revenue for the healthcare facility. So for clinical documentation, it operates as a communication tool, right? Your queries and things like that. It's critical for patient safety and continuity of care. It supports decisions made in patient care, supports reimbursement from payers. It supports services provided as legal testimony, and it functions as the provider's business and legal record. So I'm talking about clinical documentation in general. So case and utilization management. Case and utilization management programs assist providers in delivering high quality, cost effective care and are a critical element to successful revenue cycle operations. So these departments ensure that the facility is delivering the appropriate care at the appropriate time in the appropriate patient setting, reflecting the appropriate cost. That's going to be key to the concept of successful case and utilization management. So let's talk about the differences. Okay. So case management provides a collaborative process of assessment, planning, facilitation, and care coordination, evaluation, and advocacy for options and services to meet comprehensive health needs through communication and available resources to promote patient safety, quality of care, and cost-effective outcomes. So utilization management is the planned systemic review of patients receiving healthcare services against criteria for appropriateness of services being provided, as well as admission, continued stay, and discharge planning. So utilization works in conjunction with case management, and at times the terms and responsibilities are used interchangeably. So the role of case management. The case manager assumes many roles, including one of the patient advocate, the assessor, the educator, and the role has evolved to include um, the improvement of outcomes by assisting patients in managing their medications, ensuring appropriate and timely care is provided, and connecting with patients after they leave the facility. So we want to eliminate avoidable days and reducing risk of readmission by structuring care through coordination, enhanced communication, and care management. So enhancing claims management by confirming care is medically necessary, and when it's not, notifying the patient about the payer's decision and advocating on the patient's behalf to reverse the payer's decision when necessary. So these responsibilities allow the case managers to quickly identify barriers that may impede the efficient progression of the patient through the healthcare service process. So the role of utilization management. So the staff, they're responsible for the day-to-day provisions of the hospital utilization plan. So the staff works with external quality improvement organizations under the directions of CMS to support the quality of patient care and services. They also work with third-party reviewers to provide requested clinical information, facilitate health record access, supervise external insurance reviewers, and ensure communication to patients and their families resulting from the external review organization communications. Some additional responsibility I want to point out is they apply criteria objectively. That's their role for admissions, continued stay, level of care, and discharge readiness, right? They also screen and coordinate elective and emergency admissions and transfers, outpatient observations, and conversions of status as appropriate and compliant. Okay, so let's talk a little bit about, or continue to talk about utilization management in HINS that I referred to earlier. So, according to CMS, hospitals have the responsibility to issue HINS to Medicare beneficiaries prior to admission, at admission, or at any point during an inpatient stay if the hospital determines that the care the beneficiary is receiving is about to receive is not covered because either it's not medically necessary, it's not delivered in the most appropriate setting, or is custodial in nature, right? So, your commercial payers are responsible for providing written documentation to the patient or to the patient's family um, attending physician, excuse me, I was going to say admitting physician, and the attending physician and the facility of an adverse determination. So, adverse determinations represent when a healthcare insurer denies payment for proposed or already rendered healthcare services. Payers work with the hospital department responsible for utilization management to communicate their decision. So, Medicaid requirements vary from state to state for notification of denial of care or termination of benefits. So, in addition, many commercial payers also establish specific guidelines, and many commercial payers publish utilization management guideline workbooks for providers as a general educational tool to assist with compliance and formulation of a utilization program. So the healthcare facilities utilization program should include federal, state, and commercial specific requirements. So HIM professionals perform a variety of functions, but the payer, or I'm sorry, the primary related to revenue cycle involves that code assignment, right? So HIM professionals are responsible for reviewing clinical documentation and assigning clinical codes. Okay, so here on this slide represent like our coding classification system, right? So ICD-10 CM, PCS, those HCPCS level 1 and level 2 codes. And I like the way that it's broken down to if we're looking specifically based on physician or professional codes, right? And then facility and then those hospital codes. So we're going to talk more about that in future chapters. So let's talk a little bit about hard coding and soft coding. So, the process of human interaction with assessing clinical documentation and selecting code assignment is often referred to as soft coding as opposed to hard coding. So, experienced, well trained coders ensure accurate and complete code assignment and optimal reimbursement. So, your coding professionals must be skilled at reading through documentation on a variety of different healthcare forms, right, or forms in general, and formats and interpreting that documentation to arrive at the correct code assignment. So we're going to talk a little bit more about hard coding in terms of like chart master and things like that. Okay, so next, I'm sorry, I forgot to. Okay, so health information management and clinical coding. There's some key things that I'm going to talk about here, but I want you to write down these acronyms, right? DNFB for your discharge not final builds, your CMI for case mix index, and then your SMI, which is going to be your service mix index. So a bill cannot be generated until the coding is complete. So organizations routinely monitor we say organizations, but let's say like your coding manager, your coding department, or your coding leader, right? They tend to routinely monitor the discharge, not final build days. Well, organizations too, because I know that it's really important to the CFOs, right? So generally, this is done by reviewing the DNFB report that includes all patients who have been discharged from the facility, but for whom the billing process is not yet complete. So the goal of an effective revenue cycle is to eliminate any backlog of uncoded charts, and then you want to complete the coding process within the time frame of the bill hold days established for the organization. So it is very important to have experienced, well-trained coders in order to ensure accurate and complete code assignment and optimum reimbursement. So your coders must be skilled at reading through the documentation, as I mentioned before, to get that correct code assignment. So the hospital's case mix index. Your hospital's case mix index is also measured and analyzed. So the case mix index allows an organization to compare, their cost of providing care to its DRG mix of patients in relation to other hospitals for inpatient cases. So the accuracy of clinical documentation and of the code assignment can be influenced or can influence a facility's case mix index. So by missing a diagnosis or procedures that should be coded or failing to assign the most specific code possible, the coding staff can cause the case mix index to be lower than it should be. Okay? So the hospital service mix index is similar to the case mix index, but on the outpatient side. The service mix index is the average relative weight of the procedures billed for service. And again, the accuracy of capturing the services and procedures provided can influence the SMI. So when documentation is vague or ambiguous, they may have a need to query the physician for clarification, right? So the physician query process can create significant delays in the revenue cycle when the coder, is waiting for the physician's response and cannot complete the coding until it is received. Okay. So charge capture. Okay, so charge capture is going to be your method of recording services or in supplies or items delivered to patients and billed on a claim form, right? So it's going to be used for reimbursement, tracking utilization, and monitoring inventory. So charge capture is the method, again, of recording services and supplies. It's the process of documenting, posting, and reconciling the charges for services rendered to your patients. Organizational success is directly dependent upon accurately documenting and reporting charges in a timely manner. And the aim is to have policies and procedures and resources in place to ensure quality charge capture that enhances revenue and adheres to compliance and other guidelines. So while clinical staff may not view charge capture as a priority, it's important to recognize and ensure clinical staff and charge capture efforts work toward the same purpose, which is to sustain the organization's mission of caring for patients. So organizational success is directly dependent upon accurately documenting and reporting charges in a timely manner. And then your aim is to have policies, procedures, and resources in place to ensure quality charge capture that enhances overall revenue and adheres again to the specific guidelines. So the importance of quality charge capture. Quality charge capture is important for several reasons. Payments are often related to charges reimbursable for outpatient services. It's often driven by specific charges along with CPT and HCPCS codes listed on the claim form, right? So charges drive prices and rates for reimbursement. Payment rates established for DRGs and APCs are, make sure you know those two, those acronyms too. So are determined by analyzing historical cost data. And if true, costs are not being reflected, reimbursement rates are set too low. So charges reflect resource utilization. This allows an analysis and comparison of resources used for patients with similar diagnoses treated in similar service lines or receiving similar treatment. Okay, so charges help with measuring labor costs and productivity. This assists the organization in monitoring the cost of doing business and determining staff needs. Okay, so errors in the charge capture create significant rework and billing delays, as I mentioned before, and errors may also go undetected and result in a loss of revenue or put the organization at risk of not meeting regulatory requirements. Okay, so if we are looking at this charge capture example, for a simple example, consider a patient is seen in the emergency department. The patient is assessed, services are decided, including labs and x-ray and medication is provided, right? So the time spent with the patient during the assessment would correspond to an E&M charge as well as a radiology charge, right, for the x-ray, laboratory charges depending on the tests or the labs that were drawn, and then a pharmacy charge, right, for the medications that was administered during the visit. Okay. Okay, so a variety of charge capture mechanisms may be in place to get charges entered into the billing system. Charges may be entered from paper or an electronic claim form or an encounter form, or they may even be interfaced from source systems used in such areas as like the lab or the pharmacy that submit large volumes of charges. So your electronic health record systems may also be configured to apply charges to patient accounts, and health information management coding staff often has the responsibility for some charge entry based on clinical documentation. So regardless of the mechanism for charge entry, it's important to verify the accuracy of charge codes being entered and to ensure that they are posted to the correct patient account for the correct date of service. Many organizations refer to the department or program responsible to oversee charge capture processes as revenue integrity. So revenue integrity is a recently developed approach in which organizations prioritize efforts to maximize warranted reimbursement, operational, through a legal and contractually compliant business strategy. So a revenue integrity success depends on the strategies implemented involving the process, your teams, and the technology. So the primary responsibility for charge capture is assigned to staff in the departments providing the services, but there are complex regulatory requirements surrounding complex surrounding compliant charge capture. So ongoing charge capture education with well-documented policies and procedures are vital. So timely submission of charges is also crucial or critical for revenue cycle success. So each facility has a defined number of days during the bill hold period. These are the number of days in which accounts will be held from billing so that charges can be entered after the patient has been discharged. Oh, what else can I tell you about this? Okay, so separately chargeable and separately billable. So an additional responsibility in revenue cycle management is determining which items or services are separately chargeable and which items or services are separately billable. So after review of government and commercial payer charging guidelines where applicable, right, in each setting, whether inpatient or outpatient, providers need to develop and execute charge capture policies and procedures meeting organizational improved compliance practices. All right, so let's talk about the CDM. So the CDM, which is your charge description master, is an electronic file that represents a master list of all services, supplies, devices, and medications charged for inpatient or outpatient services. The CDM contains basic elements for identifying, coding, and billing items and services provided to patients. And it's the mechanism for representing captured charges on the billing form or billing claim form. So the charge master must be continuously updated to ensure that it represents all billable services and supplies and to keep up with changes in CPT or HCPCS codes, revenue code assignments, and payer-specific requirements. Any number of events may trigger a need for a CDM modification. So some examples include changes in CMS reimbursement guidelines, changes in other public or private payer specifications, modifications to allowable data requirements by a charge master or by the charge master vendor, identifying services or procedures conducted but not currently represented, every billable but not separately payable procedure, service, drug, supply should be included in the CDM. Anything that's linked in exploding charges, and then changes in department codes to represent where the charge item is captured. So other scenarios that require modification to the charge master include identification of an existing item code description and CPT or HCPCS code description if they don't match or it does not correspond to the service being provided, encountering reoccurring claim scrubbers or outpatient code editor, which is your OCE edits, indicating inappropriate charge master setup, duplicate line items. Oh, I remember when that happened to us. Duplicate line items potentially causing charging confusion or an increase in claim denials or delayed claims. So some of the core elements of the CDM is going to be, I think I'm on, no, I think I'm on the right slide. Select. Oh, I think I may have core elements. I may have been on the wrong slide. Okay, so this is right, CDM core elements. So Each billable service or supply is set up in the CDM and assigned an internal charge master number, which links it to various data elements necessary for billing and for tracking charge activity within the organization. The CDM contains the following general elements or general data elements. So we have our charge code, which is a unique identifier to identify and represent each billable service or supply. The number is meaningful only to the organization and does not appear on your billing form. The charge code description, which is a narrative description of the service or supply. It does not appear on the billing claim, but would be available on an itemized patient statement. We have our CPT or HCPCS code, and that's a nationally recognized 5-character alphanumeric code. So not all CDM line items have a CPT or HCPCS codes because there's services and supplies for which no code has been developed. So these charges are represented on the claim using only the revenue code. So an example of a CDM line item often without a CPT or a HCPCS code is your operating time charges. So most hospitals charge or services on a time or level basis, right? So a time or level charge structure initiates the intersection of the charge master with HIM and coding of outpatient accounts or for the outpatient accounts. So the trained coding professional will assign the codes and code the codes that are most appropriate for the encounter. So this process, as discussed prior, that's often referred to, right, as your soft coding or dynamic coding. So when a CPT or HCPCS code exists to represent a charge master line item, it's directly placed in the charge master file that is referred to as a statistic coding or hard coding. So many services, supplies, and pharmacy items can be accurately described and coded without, inquiring review of documentation to select the most appropriate code and therefore directed or directly coded in the charge master. So your modifiers are your 2-character numeric or alphanumeric extensions added to the CPT or HCPCS code to provide further information about the code. So the electronic claim form allows up to 4 modifiers to be attached to a CPT or HCPCS code. Therefore, the organizations may consider including multiple modifier fields in the charge master build. Okay, so the revenue code is the nationally recognized and standardized 4-digit code that provides general identification of what the line item charge represents. So more than 500 revenue codes are available to represent categories like room and board, lab, radiology, pharmacy items, therapy services, supply items, and surgical procedures. The revenue code and its description are required on each line item of a billing claim for both inpatients and outpatients. And then lastly, it's going to be your price. So the price is going to be the price per unit charge amount for the line item of service, item, or particular supply. So the next slide is simply just an example of what the CDM looks like. Okay. All right, so some additional elements which I reviewed already. Okay, when I was on the incorrect slide, so forgive me. So the CDM continuously updated due to, I talked about this already. And then your CDM maintenance. So your CDM maintenance is a multidisciplinary activity. So proper charge master maintenance requires expertise in coding, clinical procedures, health record or clinical documentation, and billing regulations. So for example, the Health Information Management Department is knowledgeable of the codes. The Patient Accounts Department knows the general ledger codes. The Pharmacy Department is familiar with the drugs and their costs, right? And then your Finance or your Revenue Integrity Department knows the associated charge formulas. So consequences of inaccurate CDM, and I kind of mentioned this a little bit throughout, but consequences of an improperly maintained or inaccurate charge master is going to be free services provided, right? Because if you're not capturing the services accurately, you're losing money, right? So missed opportunity to bill if the setup of charge after the service is provided, your billing delays or potential billing delays, the increase in costs to the organization, because basically that's what it boils down to, right? A reduction in revenue. So if the charges are not correctly set up in the CDM, or if there are errors in the way they're set up, billing edits and OCE edits may be generated. I'm thinking, I remember working those reports, holding up the processes of the claim or the processing of the claim. All billing delays result in increased account receivable days or AR days, right? So the OCE and the billing edits result in multiple individuals investigating the issues, making the necessary changes, which results in increased costs to the organization, right? Because that's going to impact somebody's productivity. They could be doing something else, and yet they're working these claims that should have been worked correctly the first time. So an up-to-date, complete, and well-maintained charge master is a significant financial operation and compliance asset to a healthcare organization. Okay, so let's talk about the back-end processes. Okay. Your back-end processes are going to include the billing system, the claims preparation, claims editing, claims submission, and payment posting. The information from the front and middle processes are combined during the billing stage to create meaningful communication to the payer to represent the patient encounter. So at the billing system stage, administrative and clinical information, including charges and all applicable clinical coding from a variety of information systems, are merged through a software module to reflect the patient encounter. So this action begins creating the bill or claim that will eventually be submitted to the payer for payment. Typically, healthcare organizations have a waiting period before the claims moves through the cycle. So as described earlier during the charge capture process, this is known as the bill hold period. So the account cannot progress through the cycle until all applicable administrative and clinical systems provide the necessary information to unite the account into the billing system. Okay, so claims preparation. So the billing system merges the account information, but the claims preparation stage involves placing the pieces of information accumulated into the respective fields on the claim. So the two methods are used to prepare, and the two methods that are used to prepare and deliver healthcare claims to payers include public and private insurers. The manual format or paper claim format for health facilities is the UB04. Okay, the manual format, right, or paper claim format is going to be your UB04. Today, most claim submissions are electronic. So providers must submit Medicare claims electronically unless the provider qualifies for a waiver or an exception. So the paper and electronic forms for healthcare facilities or that healthcare facilities currently use, they were developed and maintained by the National Uniform Billing Committee, NUBC. The NUBC was formed to create and adopt a standard set of data to be used nationally by institutional, private, and public providers and payers for handling healthcare claims. The payer and the electronic forms in current use for professional reporting were developed and are maintained by the National Uniform Claims Committee. The UNCC was formed to develop a standard set of data to be used by non-institutional providers to communicate claim and encounter information to and from all third-party payers. So data elements in the electronic format are consistent with the paper copy. So the claims are then transmitted to a data clearinghouse, and that's where the data is held for claims editing. And I think that it's important to note, let me go to the next slide really quickly. Okay, so now we're going to talk about claims editing. But before, I mentioned the manual format, right? So healthcare facilities, they use the CMS 1450 or UB04, right? Healthcare facilities, so that's the paper claim. But when we're referring to professional, that's going to be the CMS 1500. So you want to know the difference between the 1450 and the 1500. Healthcare facilities versus professionals. And then when we talk about the electronic formats, the healthcare facilities use the 837I, and then professional, that's why it's easy for you to remember, is going to be the 837P for professionals, right? Okay, so let's go back to talk about claims editing. Okay, so when errors are detected, reports or the electronic record work queues should generate. Okay, let me start over. As errors are detected, reports or electronic record work queues should be generated to be reviewed by the appropriate staff. So charge or coding corrections can then be made if supported by the health record documentation. Trending the errors can assist in identifying sources of inaccuracies and provide data for meaningful staff education. The overall objective of the claims editing process is to ensure accurate claims for maximum payment for the services provided and shorten the amount of time from claim submission to payment processing. So organizations may utilize internal billing edits designed to detect and correct charge capture errors before claims are submitted to the third-party payers. They may also utilize APC Grouper, like an APC Grouper software, or a Medicare claim scrubber software, which is designed to detect errors that would result in payer denials. Common edits include a male patient with charges for a procedure that could only be performed on a female, or reporting charges for a blood transfusion without any charges for a blood product that was transfused, right? So as errors are detected, they should then appear on reports or in a record work queue that are reviewed by the appropriate staff member. So the Scrubber software usually includes standard edits, but it's also customizable to accommodate payer issues as the healthcare organization may have experienced in past claim submissions. Standard edits are uniform edits developed by CMS. So depending on the patient type, inpatient or outpatient, a series of edits are publicly available to incorporate onto a claims scrubber software. So the Medicare edit or the Medicare code editor, which is the MCE, is the inpatient code editor used to detect various claim errors. So the integrated outpatient code editor, which is the IOCE, validates complete and accurate outpatient claims. So part of the IOCE is the National Correct Coding Initiative, which is your NCCI. So CMS developed the NCCI to promote correct coding methodologies and to control improper coding, leading to appropriate payment. So another outpatient specific edit enacted by the CMS is medically unlikely edits, which is your MUES. So a MUES identifies CPT and HCPCS codes reported with units greater than what has been deemed appropriate. So this was on that other report that I used to work on too. So MUs are maximum units of services a provider would report most circumstances for a single beneficiary on a single date of service. So common edits are written specifically to ensure claims comply with certain payer rules or to identify common issues experienced in previous claims. So what common custom edits includes reporting charges for a blood product transfused, but no indication a blood product transfusion was performed. So that's opposite of the other one that I mentioned. Or a pharmaceutical item requiring injection or infusion is present without the administration of the procedure, or a fracture diagnosis code is present on an emergency room claim without a fracture treatment procedure. Okay, so dropping a bill. So the activity of submitting a claim is often called dropping a bill. Reimbursement for clinical services provided in the healthcare facility, largest source of revenue. So timely and accurate submission is necessary. Most billing systems are programmed to automatically submit claims to the payers, which is after the bill hold time that I mentioned earlier, right? So if an account is not being held for any type of edit resolution, these are often referred to as clean claims. So the goal is to continuously increase the percentage of clean claims that can be billed with no intervention. So the sophistication level of an organization's billing system determines how much is able to be programmed into the system versus how much has to be handled manually by the billing staff. So timely filing is an important consideration for all payers. So your Medicare claims must be filed to the appropriate contractor no later than 12 months or 1 calendar year after the date of service. Commercial payers may follow Medicare's timely filing rules, but many commercial payers require a much shorter time period. So the provider must recognize individual payer requirements on timely filing for the submission of claims. Okay, so let's move on to payment posting. So after claim submission, the payer processes the claim for payment. Payment is received from third-party payers and patients in various ways, and the payments must be posted to the correct individual accounts. So the payment will pay, adjust, and pay or deny either in full or in part. So So internally, some of the allocation of the revenue must be made to the various areas that provided the services. So in the this process is established by the organization's financial accounting area, and the method of allocation may vary. So since payment received usually doesn't equal the amount that was billed, it's a complex process to determine the correct allocations and to post the necessary payments, adjustments, and discounts to the correct accounts. So ultimately, the balance on each payment account must equal zero. There are instances when too many payments are posted to the accounts because there can be multiple payments from one or more insurance companies and co-payments or co-insurance that's received from the patient. So in these cases, the patient has a negative balance, and it must be determined where the overpayments occurred so funds can be refunded to the correct payer or to the patient. So organizations routinely measure their AR days, right? Your account receivable days. And the average number of days between the discharge date and the receipt of payment for services rendered as a measure of how successful the revenue cycle is. So a low AR value is going to be favorable, right? An efficient revenue cycle helps the organization lower their AR days, which in turn improves the cash flow. Collections and account follow-up. So collections and account follow-up includes claims adjudication, any discounts and adjustment, deductibles for the co-insurance and co-inpatient, the co-payments, excuse me. We want to make sure that the billing is patient-friendly, right? Including the ways to pay. Do they have to mail a check? Can they do it through the online portal? Think about things like that. The collection process, what does that look like if a patient fails to pay? And then are we not using any third-party collection agencies? So denial management. Denial or denials in general may simply be defined as a payer's refusal to provide a partial or full payment. So a study done by Change Healthcare using facility inpatient and outpatient claims showed back in 2016 for a typical health system, as much as 3.3% of net payment revenue. This may sound low, but that averages 49 million per hospital was at risk due to denials. So Change Healthcare also reported 63% of denied claims are recoverable on average. So the front end processes cause the largest percent of denials, with registration eligibility as the most significant reason. So again, the most common denials are going to be the registration and eligibility, missing or invalid claims data, failure to get the authorization or pre-certification, medical documentation that requested that wasn't provided, the service wasn't covered, medical coding issues, medical necessity issues, it wasn't filed timely, or the appropriateness of care. All right, so what do we have next? Denial management programs. This is really important. So a denial management program requires facilities to seek both prevention and recovery. So denial management requires a cross-functional team to evaluate reasons for denials and to facilitate changes in work processes to prevent further denials from occurring. Right? So a successful denial management program must be based in core analytics, meaning to use tools to assist in understanding available data and detail to inform and educate. So a successful denial management program requires consistent focus and evaluation of denial trends. So findings from trends or patterns identified needs to be shared on a reoccurring basis with denial management stakeholders because identifying the root cause of the denial and then analyzing such information to determine the significance of impact, it shows for or it allows for a strategic approach to prevent and manage those denials. Okay, so remittance management. So you may have seen RA, right? Remittance advice or the 835. I mentioned this earlier. So your 835, um, so let me take a step back really quick. After payers process claims, remittance advice files are provided with final individual claims adjudications and payment information. So government and many commercial payers utilize electronic remittances. The electronic file format adopted as the National HIPAA Electronic Remittance Advice, the ERA, standard is X12 835 version 510, or more commonly known as 835, right? So your RAs provide explanations through itemized claims, processing decisions, information about any adjustment rate. So the payment information can be used to determine revenue audits and recovery efforts. So your RAs provide explanations about any payments, deductibles and co-payments, adjustments, denials, missing or incorrect data, refunds, and then claims withholding due to Medicare secondary payer, MSP, or penalty situations. All right. So then you always want to make sure that you do a revenue audit, right? So was the provider paid what they were expected to be paid? And then when you're attempting to, if they weren't, right, you're going to attempt to recover. So if the answer is no to the revenue audit expectation, determine the efforts for investigating the payment variations, right? So is it related to a specific payer? A specific payer type, whether it be inpatient or outpatient? Are there more high dollar cases or low dollar cases? So really try and take a look at those trends and figure out what could be impacting that change or that difference in terms of payments. All right, so support services. So while payer relations and patient relations are not directly involved in the day-to-day flow of patient accounting, the activities associated are essential to the success of revenue cycle processes. So building collaborative relationships with data sharing and transparency for both payers and patients advances the organization through trust and a higher quality of care. So healthcare facilities negotiate contract terms with third-party insurers for payments of services rendered to patients. So health plans, the contracts, the health plan contracts include two specific components. The first is the basis of payment. This section includes contract language indicating the administration of the contract, allowable costs, chargeable services, hierarchy payments, and supplies provided by the hospital or physician that quantify or that qualify as service as covered expenses are defined. Second, the contract includes the payment terms or schedule. The contract terms need to benefit and be cost effective to the facility, its patients, and the insurer. So contract management has its own life cycle, and the contract managers need to understand competitor and local market rates to negotiate reasonable reimbursement rates that cover the healthcare organization's expenses while remaining competitive. As discussed in the remittance management section of this chapter, tracking variances from contract terms and understanding the root cause and responsible parties for the variances is extremely important. Okay, so patient relations and customer service. So the organization's revenue flow is impacted by the relationship with the patient. As more financial responsibility shifts to the patients, providers must focus on communicating about the care and the financial obligations. Usually, the last experience regarding the patient encounter is involving the bill. So the organization should desire to create a positive last experience. Creating a positive patient experience is essential to healthy revenue and a healthy future for the organization, because that's what's going to build loyalty, right? Patient satisfaction and loyalty. Okay, so some measures for performance improvement. It's so important, especially when we're talking about the revenue cycle, to measure, monitor, and set goals. We want to make sure that we have key performance indicators, which are your KPIs. So to determine how successful healthcare organizations are at achieving set performance goals, your KPI must be selected. KPIs allow healthcare facilities to measure and benchmark their data against best practice. So measuring the various processes of the revenue cycle against established benchmarks provides an opportunity for an organization to focus on areas to improve. So influences such as the geographic location, the bed size, the payer mix, what else? Payer mix, net patient revenue, and the mix of inpatient, outpatient, and emergency visits can all impact your revenue cycle. All right, so one of the last concepts in this chapter is going to be about your MAP keys. I remember briefly mentioning this in a previous video, but the HFMA directed development from industry leaders for indicators to consistently measure the KPIs. So these strategic KPIs set the new standard for revenue cycle excellence and are known as MAP keys. So MAP represents the comprehensive revenue strategies to measure, perform, and apply evidence-based improvement strategies and perform to the higher standards to improve financial results and patient satisfaction. So the MAP keys are comprised of 29 KPIs for revenue cycle benchmarking, and they're separated into 5 major groups. Those 5 groups are patient access, pre-billing, claims, account resolution, and financial management. So these are some examples of MAP keys. You should be able to find them in your book, so I'm not going to spend too much time on this slide. Okay. And that's really it. That concludes the end of chapter 8, which is revenue cycle operations. I know this was a long, comprehensive or chapter summary, but revenue cycle involves a lot, and HIM is a part of revenue cycle, right? So I wanted to make sure I gave you a much longer chapter summary because some of the things or topics or concepts covered in this chapter can be a little bit confusing. So if you have additional questions, please be sure to drop your comments below in the domain for Q&A forum. All right, I look forward to your questions, and I hope that you found this video to be helpful.